Welcome. My name is Venus Chow, and I'm a physical therapist and a regional manager for Theragen. Today we will be reviewing how to perform range of motion. You want to start with the height of the bed. You don't want it to be too low because you'll be bending your back, and you don't want it to be too high. So just start with a height that's comfortable for you. You also want to start with a wide base of support so that you can move between both legs and get that power from your legs and not just from your arms. The goal is to get the full range of motion, but of course to the patient's tolerance. So you definitely want to support each joint, and the one thing that I would do differently is not be so pokey with my fingers. You want to have a flat hand as much as possible. So you want to move in the direction that the joint is moving, and that way you can get that weight shift and all that power from your legs. You see I've switched positioning to going backwards this way because now we're doing shoulder abduction, and before we were doing shoulder flexion. You want to hit all the major joints, including the shoulder, the elbow, the wrist. If you notice, all of these movements are passive. When you get down to the wrist, you want to support the arm so that you can isolate and focus on just the motion of the wrist. That's why I put the pillow underneath. Here we have active assisted range of motion. You want to be able to cue the patient to initiate the movement as much as they can, and then you want to finish that range. The main difference between the passive range of motion and the active assisted is passive, the patient's doing nothing at all, you're completing the full motion. Active assisted, the patient does have some movement and you're just helping them to achieve the full motion. So once you move on to the leg, you're going to need a wider base of support. You're also going to support the leg underneath the thigh and the ankle if possible. It's important to keep your eyes on the patient's face at all times because even if they won't tell you, they will definitely show you if they're in pain. Keep in mind your body mechanics at all times, unless you have incredibly good insurance and wouldn't mind being a patient at our facility as well. You want to protect your back because you only have one. When you get to the knee, you want to prop that knee up underneath the thigh. That gives you a little bit of room to actually have that leg come up. It's good to support the ankle, and again, not pokey like you see right here, but with a flat hand as much as possible. It's also good to put your hand on the end of the thigh and just see if you can feel that muscle contracting. You want to give the patient commands, kick up, kick up. You also want to prop the ankle up, but be sure that the patient does not hyperextend that knee. It puts a lot of pressure on it and causes them discomfort. Here you just have the ankle hanging and you're again looking at the patient's face to see if they make any sort of grimaces. Now to get into something more exciting like bed mobility. Here we have a 2-person assist sliding up in bed. We bring the bed level up again. We also bring the foot of the bed up so that gravity can assist. We have the patient cross their arms across their chest, lift their head. You hold the sheet very close to the body and then slide up, making sure not to hit their head, please. So here we have a supine to sit transfer, or what we like to call a log roll. You would start by again bringing the bed height up. You'd have the patient bend their knees. You'd instruct them to bring their arm across to hold on to that assist rail, and then you'd roll them with your hand behind their shoulder and their hip. You start to move the legs off of the bed and instruct them to push up at the same time. One thing I could have done differently is to have my hand positioned behind the shoulders of the patient versus the neck for less discomfort. Moving on to transfers. For the transfers, you want to start with the placement of the wheelchair near the bed. You want it to actually end up being adjacent. Of course, locking the brakes prior to trying any transfer. And of course, you would always put a gait belt around their hips. From here, I readjusted the bed because for any transfer, you usually want to go from higher to lower. But you also want to make sure that the patient can still touch the floor with their feet. So have them scoot back out again so that their feet are touching the floor. To make it easier, bring up that side rail if you can on the wheelchair. And then to place your feet, you want to have a wide base of support with one leg pointing towards where you're going and one leg actually helping to block the knee of the patient. It's also helpful to have the patient reach towards the opposite armrest. Bring the patient very close to your body, and you do that 3-time swing. Bring them close, and then bend your knees to have them sit. For patients that you're unsure of their level of assist, or for heavier assist patients, you want to get a second person for safety. You'd have the patient scoot towards the wheelchair. In this instance, you would have someone behind, someone in front, and then of course you would bring them close again, do that 3-time rock, and bring them over to the wheelchair. To make it more exciting, you could always use the sliding board when you don't have a second person assist. You again would bring up that armrest that's closest to the patient in the bed, have the patient weight shift onto their opposite elbow, lift their butt, and then be careful with the placement of the sliding board. You want enough purchase underneath the butt and enough on the actual wheelchair itself. You definitely want the sliding board pointing towards the wheelchair, and you always want to point out to the patient to keep their hands flat. They have a tendency to try to curl their fingers and then they end up crushing them. So to avoid that, just keep their hands flat at all times and be mindful of their legs moving as you do that sliding board transfer. You rock up on 3 and help them to scoot. Usually takes about 3 scoots to get over to the wheelchair. And then you have them weight shift onto their opposite elbow and take that sliding board out, hopefully more gracefully than you put it in. Next, we're going to do the toilet transfer. You'd bring the wheelchair again adjacent to the toilet. Lock the brakes, of course, for safety. Have the patient scoot all the way to the edge of the wheelchair. You're going to want them to again pull up with one hand and push down with the other. Pull up that armrest that's closest to the toilet. Get yourself a wide base of support and rock with them 3 times. That makes that pivot very, very easy. So as that patient backs up to the toilet, this is when you would normally take their pants down, but for our purposes, we did not. Now we'll move on to ambulation. So you start, of course, acknowledging the patient, introducing yourself. You would make sure that the brakes are locked prior to putting on the gait belt. Make sure that gait belt is nice and tight, but comfortable. Have the patient scoot to the edge of the wheelchair, and then you tell them to put one hand on the walker and one hand onto the wheelchair. You place your hand on their gait belt, wide base of support for you, and then you rock up on 3. Once you get up to standing, you can always make sure that the size of the assistive device is correct by having the patient stand up all the way and relax one of their arms, and it should be around their wrist level. Once you start walking with them, it's pretty much giving them the direction of the device first and then their legs. The wheelchair follow is a little bit easier if the person doesn't need that much physical assist, but if they do, then you would get a second person for safety. Prior to them sitting, you want to lock both brakes, have them walk back to the wheelchair, bring the walker back, and then reach back prior to sitting. Next, we'll move on to a single point cane. You want to always ask the patient which is their weaker leg or the painful leg, and then you want to give them the cane in the opposite hand. It would start the same way as with the walker. You'd have them scoot out to the edge, brakes and gait belt on, one hand onto the wheelchair armrest and one hand on the cane, and then you do that 3-time rock. Always make sure the patient is stable prior to initiating walking with them. And they're always going to put the cane out first, and usually then move their weaker leg and then their stronger leg. Make sure they don't put the cane too far out or too far in front. It should always be just a little bit in front and to the side of them. On to precautions. When working with a catheter, you want to make sure that you take it from the wheelchair. You always want to wear gloves. You want to make sure that that catheter bag is covered with a dignity bag, and you want to put it appropriately where it should be placed. We all void downstream, so it should be below the bladder level. When we're showing you the incorrect way to put it, it would be very high up and possibly very uncomfortable for the patient. So this is the correct way to do it, as you can see. This is what happens when you forget to take the catheter bag from the wheelchair. Oh yeah, it hurts. Also, it should never hit the floor. And you really should never be on your phone while you're walking someone.
Look at me.
So for the hip precautions, a good way to show someone how to stand up is to keep that foot out, to do just a little bend, and then a push up to stand. So you're not supposed to bend over 90 degrees, you're not supposed to cross the middle of your body, and you're not supposed to point your toes in. See what happens when Francois demonstrates what I'm telling him not to do.
Oh, my hip bone.
Yep, he's going back to the emergency room. And I said not to do it. If the patient had an anterior approach to their total hip, you want to avoid hip extension. Now on to sternal precautions. You want to explain to the patient that they have an incision in their sternum or their breastbone. You want to explain that every time that they cough, there's a pressure that's pulling that out. And in order to counterbalance that, you want to show them splinted coughing, where they use a pillow and they press in every time they want to cough. That way you counter that pressure to go out. The other precaution is not to push or pull over 5 to 10 pounds. The correct way to show someone how to stand is to have their hands on their legs and to scoot out to the edge, rock up to standing. Sometimes you can give them this tactile cue where they use the pillow to avoid using their hands. So for sternal precautions, think BLT. And not bacon, lettuce, tomato, but no bending, no lifting over 5 to 10 pounds, and no twisting.
Nurse! I'm thirsty on water.
Hey, yeah, no, I'm not doing
Give me
anything.
the water.
Wait.
Nurse, hey, what are you doing? Give me water.
I did see that. Hold on, sir.
Nurse!
I'm
here.
trying to get my attention, but
I'm thirsty. Give me water.
Oh,
What are you doing?
that was hilarious. Let me go somewhere where I'm not being bothered. When I show Francois how to get up, I want to make sure that he rolls onto his back and that he checks his joints first. So I have him move his wrists, his elbows, and his shoulders. I do the same for his legs. I ask him to try to move each leg up into hip and knee flexion, and then on the other side. Usually if there isn't any pain, that's indicative that you don't have a fracture and that you can go ahead and try to get yourself up. I ask him to pull himself up to sitting, and then I ask him to scoot towards the bed. Once he gets close enough to the bed, I ask him to get onto his side and then into a lunge position. This is usually where you would have to help the patient, especially if they can't get onto their side or into that lunge, and help them to get up to that bed or the chair, whatever's nearest. After a fall, don't forget to have a good IDT meeting with a root cause analysis and a trial of different interventions that you haven't done before. And that's it. Remember, kids, you too can prevent falls by having a really good baseline.